Ciao, buonasera, ciao Pasquale.
Buonasera.
Aspettiamo un attimo che le persone si connettano, così da cominciare, che ancora siamo online, ma non c'è ancora nessuno connesso. Allora, intanto, siccome poi questo rimarrà registrato, ecco, vedo che le persone cominciano a connettersi, siamo a 10, fa parte di una serie di webinar che stiamo organizzando con l'Università di Roma La Sapienza e con il professor Parisi sulle emergenze pediatriche, sulla gestione delle emergenze pediatriche. Quindi, siccome si stanno connettendo le persone, mi tolgo e ti lascio introdurre la serata e l'argomento. A te, Pasquale, la parola.
Okay. Thank you so much. Dear colleagues, dear friends, this evening we are going to have a great opportunity for our pediatric school at Sapienza University, because we will have a meeting, an important meeting with an international expert on pediatric resuscitation and on neonatologic resuscitation. And Vinay Nadkarny, Professor Vinay Nadkarny, is going to give a speech on a crucial topic, the teamwork in pediatric emergency. So, Jacopo Pagani, could you please introduce our guest?
Yes, of course. Hi, everybody. And I strongly believe that teamwork is one of the key ingredients for such successful resuscitation. And for this reason, I invite today Professor Vinay Nadkarny, one of the world's leading experts in pediatric resuscitation, and to discuss this topic. So with us as discussants, we have two young pediatricians, Matteo Cianci. Hi, Matteo.
Hey, everybody. Hello.
And Margherita Velardi. Hi, Margherita.
Hello. Hello, everybody. Hi.
And
Hi.
all the doctors of our university connected via web. And everyone can participate by asking questions in the chat. You more people say buonasera, good evening, and after we can say my question is, and I select one of your question and I put on the screen. So now I introduce Professor Vinay Nadkarny from Philadelphia. Hi, Vinay.
Hello.
Hello.
And
Hello.
great pleasure. You can start your lecture, and then we go to have our discussion.
Well, thank you so much.
Hi.
It's a great pleasure, and also to see Margherita and Matteo again from the Pediatric Simulation Games, and to spend a little time with you talking about changing the culture of resuscitation from an individual sport to a team game. Next slide, please. We all know that when we train very hard, like in sports, we can become a champion. But the goal these days is to change a team of champions into a championship team. And as Matteo and Margherita learned at the Pediatric Simulation Games, it's not only a single expert that makes the teamwork fun. It may not be a senior person like Pasquale, Jacopo. It's the team. The team is only as strong as the weakest link. But what we find is that the performance of resuscitation or any complex procedure is a combination of what we know, medical science, the educational efficiency, what we learn, and the local implementation, what the system can do. And the Each of these are important factors that we multiply by each other in order to improve the survival or long-term quality of life outcomes for our patients. Next slide. We know that going from knowledge discovery to the processing and training of that knowledge to the transfer of that knowledge into important outcomes is oftentimes slow and difficult. Next slide. And we also know that as we go through this rigorous chain, we oftentimes drop or lose in translation from knowledge to guidelines to standards to training to doing well. And so it's only by a process of rigorous evidence evaluation, deliberate practice, audit, and debriefing that we can improve the outcomes. Next slide. We know that almost 80% of the medical errors that are made on teams are errors of communication, not of knowledge, not of skill, but a communication that prevents what we know should happen from actually happening. Next slide. We also know that our patients are very diverse. And although we can have patients who are oncology patients, septic shock, intracranial hypertension, whatever it is, we oftentimes try to standardize care and boil it down into a single algorithm, like the PALS or the EPPLS algorithms. And we know that there is some benefit to standardization, but we also know that certain patients have certain pathology that requires special resuscitation circumstances. So how do we get improvement in care by standardizing and decreasing variation? And at the same time, how do we respond to those who lie outside of the normal pathway? Next slide, please. So we strive to train the individual with low intensity, high frequency training for skills, performance feedback of the team during the resuscitation or the event, and then after event reflection and debriefing so that we can train and evaluate the system for the next patient. These three elements, the individual, the team, and the systems, are all important, and we're going to focus most today about some questions and discussions about the team. Next slide. If you think about a really high-performing team, we can think about the race car drivers and the Ferrari team that really does an amazing, amazing job at being able to really, in a very time-efficient manner, get all the time-critical interventions as a team to happen. So, Jacopo, if you could play the first video, we're going to see this team in action, and it's going to take them 6.2 seconds to safely change the tire on this race car vehicle. Jacopo, can you play the first video? Amazing. Jacopo, can you play that same video one more time? And this time, I want you to watch the man holding the lollipop, the director or the leader who is holding a red or green stop sign for the team. Jacopo, can you play it one more time? Here he is at the top. He's holding this at the top, and he's organized the team. But let's go back in time. Jacopo, if you can play video number 2. And let's think about how it was and how we got there. Because in this next video, you're going to see the Indianapolis 500 race car race from 1950, where the changing of the tire is very, very different.
But Holland comes in for a pit stop. Time to refuel and change tires. Lou Moore himself changes the tires.
Look at them banging on
Only 4
those
crew
tires.
members, including the driver, are allowed to work on the car. It's a tense time. Holland stays in his seat, anxious to get away. Let's watch.
He could almost get a haircut during this tire change. One tire done. Now he has to do the next tire. Jacopo, you can stop video now. Now this third video is a different team in Melbourne. And they were sort of trying to be like the Ferrari team. Let's watch how they do, and let's time how fast it takes them to change the tire. Unfortunately, this team had not done all of the safety standards, so they were only as good as their weakest link. They went very fast, but faster than the capability of the team, and therefore they had an error. And this was a big problem. So we can see that things can be done very fast and efficiently, but if we try to exceed the capability of the team, we can still come up with bad outcomes. Next slide, please. Now, at the Children's Hospital of Philadelphia, where I work in Pennsylvania, USA, we have 540 pediatric beds in our pediatric hospital. Now, 200 of these, or 40%, are ICU beds. We have 40 attending physicians. We have 16 fellows. We have more than 100 pediatric residents. We have more than 500 pediatric ICU nurses, 100 respiratory therapists, and many, many other providers. Our code team of 5 people, if gets called to any code blue within our hospital, the number of combinations of people that might respond in 5-person teams to one patient who has cardiac arrest in our hospital on any given day is more than 1 million combinations of teams. Therefore, training people to be good team members for Code Blue is extremely difficult, time-consuming, and we must find an answer that does not require a lot of time or effort. Next slide. So we have gone to a system where we do low dose, high frequency training, little bits of training along the way so that we can boost the competence of the providers in very small doses very frequently. Next slide. We also use live capture video of our resuscitation bays so we can capture the events that are happening and debrief them in either simulation or real cases, capturing the monitor, the ultrasound, the video laryngoscopy, and the team behaviors all at once on the same screen so that after the event we can review it and critique it and figure out what went well and what could be improved. Next slide. In our delivery room, we are using advanced technology in order to study resuscitation. We're using eye tracking software so that the eyeglasses are tracking the eye movements and seeing when it's looking at the patient, at the monitor, at the other people in the room, and how they are situated around the room. The eye tracking, the red is the hot spot, green is the not so hot spot. And you can see that the face of the baby and the belly of the baby and the chest of the baby are where the resuscitation leader is looking. Next slide. In fact, in our resuscitation bays in the emergency department, we're starting to use advanced technology to track the brain blood flow of the team leader and the charge nurse using functional near-infrared spectroscopy. Dr. Pasquale, you know a lot about this. But the brain blood flow and also then tracking the task load of the participants in the resuscitation event can start to map and give us a geographic area when task load is being exceeded and when they need to hand off tasks rather than try to do them themselves. Next slide. In fact, we're starting to implement the CPR coach. Next. This project was studied in simulation by Adam Cheng, and next slide, demonstrated that a CPR coach, when implemented, next slide, could improve the quality of CPR, depth, rate, chest compression fraction improved, and next slide, the duration of interruptions or chest compression fraction was improved. There was less duration of interruptions of chest compressions when a CPR coach was used. Next slide. And this type of approach was used by Betsy Hunt at Johns Hopkins and demonstrated improvement in the time-critical interventions with a CPR coach. Next slide. This coach is based on human factors analysis of teams during resuscitation. Next slide. Where you can see that the airway and the resuscitation leader are at opposite ends of the bed. The airway manager at the top, the resuscitation leader at the bottom, and the CPR coach on the right-hand side next to the monitor and the defibrillator. You can see that a triangle forms between the chest compressor and the CPR coach and the airway manager, airway fellow. And there's also a triangle between the resuscitation leader and the chest compressor and the CPR coach. These two triangles are a way to improve communication and performance. Next slide. We have started to study the ergonomics of the human factors and the placement. So after every resuscitation, we map out where people were standing, where equipment was, and whether that choreography could be improved. Next slide. We are starting to do this not just in our ICU and resuscitation bays, but going out to emergency departments around the city and around the country and taking test cases in simulation and responding to 4 different standardized cases to see how the response goes. Next slide. This is an opportunity to see how the structure of care and process of care is being done. Next. And how it is reflected in patient outcome. Next slide. We can look at the impact, and what you can see in this slide is that as we go from low volume to medium volume to high volume centers, the readiness to respond to pediatric emergencies improved. Next slide. We did this across the country in about 11 different states. Next slide. And we were able to generate report cards for different types of simulated cases: foreign body, airway obstruction, sepsis, seizures, and then we generated scores, and we can compare the individual pediatric emergency department score with those of low volume hospitals and also with high volume hospitals, so they have a benchmark. Next slide. These readiness scores can be broken down for the institution into components of quality improvement, policies and procedures, patient safety, staffing, equipment and supplies, and give them a benchmark of their institution compared to pediatric institutions or adult institutions across a large geographic area. Next slide. In fact, from these report cards, we can generate details of where their latent safety threats are and what components they have to improve. Next slide. And we can generate with them or for them a plan for remediation and improvement. Next slide. These types of processes have been published in JAMA Pediatrics and shows great variability across the quality of pediatric readiness for emergencies across many different emergency departments. Next slide. So you can see that our teamwork and performance, it's very important that the medical science, education, and implementation are all at very high levels in order to improve survival and survivorship. Next slide. So with that, Matteo and Margherita, let's maybe open it up for some questions and comments. Thank you.
Thank you very much, Vinay. I introduce Matteo, Margherita, and Pasquale for the questions. It's very interesting lecture, and but for our culture, we are in the future. Our model is one-man band, so the doctors have is like 50s models of teams in that you show in the video. So my first question is, where do you think we should start to form a good team?
So, Jacopo, I think it's a very good question, where to start. There's not one place to start that's universal. It's finding your need. It's auditing your practice to know where the problems and issues are, but also auditing your performance to know where you're performing very well. I often find it easiest to start by looking at what's done well, because people are very willing to share and talk about what they do very well. And from that, people start to say, well, we do that very well, but we don't do this very well. Why? If we start to ask why, then we can start to uncover what people want to fix. And if we start with what the people want to fix, then it works much better than telling them what they need to fix. Because if somebody tells me, you need to fix this, then the first response is defensive, as if you're criticizing, as if you are reprimanding or punishing them. But if you ask them what needs to be fixed, the people in the trenches know what doesn't go well, and they want to fix it. They have good hearts. So I say, audit your practice, identify where you're not meeting your goals for time-critical interventions, teamwork, whatever, and start to focus on that first. Because once people see that you fix a problem they want to fix, they come to you with more problems and say, can we fix this the same way? Can we fix that? And you can build your way up until you have the complete portfolio.
Yes. What about the retraining, the importance to speak the same language during resuscitation? So this is a big problem in our hospital, but I think in more hospitals.
Yes, and I think this communication, we mentioned that 80% of the errors that are made are frequently communication problems. Now we're wearing masks, we're wearing eye covering, hats, gowns. gloves, we're having more trouble communicating, even on Zoom. If I cover my mouth like this, you have more trouble hearing me than if you can see my lips moving. So we know that the communication is key. This is why the ergonomics, thinking about the ergonomics. Margarita, I'm going to ask you, remember in the simulation games, when the
Yes.
leader got involved in the resuscitation, when they started to intubate, started to put the line in, started to move around the bed and remove themselves from the foot of the bed, the rest of the team members didn't function as well.
No.
Just was it was a matter of physical placement on the team.
Yes, I remember it was really important, the role of the team leader, and it's very difficult when you try to be the team leader to just focus on all the scenario without like focusing on one single problem. And I think it's difficult because you need to trust the people you're working with, and just believing that they will do the job, and they will let you have the feedback of what they're doing, because it's important to have like the global situation. And if the team leader like tries to resolve one or another problem, and that's the point where you're going wrong. And this, I remember it was the difficult part when we tried to be team leader. So yes,
Yeah.
I agree with you. Of course, it's really important, but it's difficult. And I think the practice, it's the basis to have good results for
Yes.
everything in the emergency.
Other things we noticed, and you guys probably noticed this, but I'm just going to bring it up, that sometimes, let's say a woman has a very soft voice or is a very shy person, and for them to be the team leader is sometimes quite difficult in a very noisy, crowded room, or in certain circumstances. They may not be tall or loud like Matteo, and so they may not be able to command the room the same way a Jacopo might be able to do. So we teach them, sometimes we have step stools in order to do better quality chest compressions, but maybe one step stool comes to the team leader so that Margarita can step up on the step stool, be a little taller. And maybe instead of her voice getting louder, she starts to make her voice go softer, so that people have to be quiet in order to hear what she has to say. And so there are certain things that can be done to improve the quality of communication in difficult circumstances.
So Matteo, you have any question?
I have a question about it. Has to do with, you already spoken about a little bit before, there's a really big number of possible teams inside a single hospital. So the most frequent situation doesn't involve a team of members equally trained. And for example, 2 years ago in Latina, you told us to form different groups with different members. Some of them from a certain university, some of them from another university. And I remember that the most difficult thing was to remember names. That seems to be a stupid thing to remember names. But I think, okay, you can't remember names. You can't see people in their face because now we have a mask. So do you think, at least in your experience, did you encounter such similar situations where you don't know a single person, you don't know his ability, his skills, so you don't know how can you be trustful?
Yeah, this is even more important in the COVID era with all of the PPE. So what we have started to do is to put a piece of tape on our forehead, which has our name, or on the mask, our role, so that you can say chest compressor, medication nurse, whatever it is. It could be my name or it could be my role. But by doing that, some hospitals like Stanford have made slap bands where they have a wristband they can slap, and it goes around there, and it has their role on that. So the team leader can quickly see who's supposed to be doing chest compressions, who's supposed to be doing intubated. Now, as Jacopo said, you're a one-man band. You may not have as many people around the bed as we have in the United States, but you can think of similar processes, maybe the label on the forehead or the mask that gives you a very quick way to call people by name or roles.
But I think that the major problem is that many people think that teamwork has no influence on survival. Okay, so you can tell us about scientific evidence to can demonstrate the importance of teamwork.
It's a very difficult. It's very difficult to study and prove that it's the teamwork that is actually improving resuscitation, because teams that do excellent teamwork also usually train more on the skills and behaviors. So divorcing out the teamwork component is quite difficult. The way we tried to do it was we did a sequential training to see if we could change the quality of CPR and the survival outcomes. So we started in our hospital, we measured the quality of CPR using recording defibrillators, depth, rate, no flow fraction, etc. We found out we were 30% of the time in compliance with in our country, the USA AHA guidelines. So we said that's a problem. So we went around and we trained all of the people. Here's one mistake we made. We trained a lot of physicians. We found out physicians don't do a lot of chest compressions in our ICU. The nurses, the respiratory therapists, and the EMTs do most of the chest compressions. But we trained a lot of doctors, and the people who were doing the compressions were somebody else. But we trained everybody, and we trained them very frequently. And on the mannequins, they did great. We started to measure their performance on the patients. Good. Survival didn't change. So then we did a number of other things of training, PALS, etc. Still didn't change the needle. The process of care got better. Then we started debriefing. We started doing this after each event, and after 2 weeks after, we started debriefing the events and talking about team behaviors and what could be done better, etc. Then not only the performance improved, but the survival outcome doubled. So wow. Some went from 29% to 50% survival from after cardiac arrest. Pretty good. And 80% of those who survived had good neurologic outcome. So pretty good. Not perfect, pretty good. But the point was, until we started doing the team debriefing, we didn't improve the outcome, even though the individual components of the skills and behaviors were improved. So I think it takes the combination of skills and behaviors and the teamwork to make a difference. One or the other. It's like a link in the chain of survival. One alone doesn't make the difference.
Okay, and what about the feedback after the resuscitation? Because many people in our culture feel judged.
Yes, ours too. Ours too. It's the way. It's got to be the way. The way it's debriefed is very important. There are several methods of debriefing, as you know. Yes. One is called plus delta. What went well plus what could be improved. And if you try to just correct in the debriefing, everybody feels bad. Everybody leaves feeling they did a bad job and they have a lot to correct. And I don't want to come back to another debriefing. But the other way of debriefing is more of what they call advocacy inquiry. I observed, very neutral. I observed that this and this and this happened.
Why?
And I was wondering why. Why? You're trying to get to the frame of mind of why did this happen? Not what happened. It's a fact what happened. But why? And what you discover is that nobody was trying to do a bad job. Everybody was trying to help, but they thought that not speaking up, or they thought that drawing up 10 different vials of different things and handing them off was better than drawing up one and handing it off. And so you observed a delay of getting epinephrine to the patient. That's what you observed. But you're wondering why. And the doctor was thinking the nurse was just a bad nurse and hadn't drawn up the epinephrine. But the nurse was trying to be helpful and draw up 10 doses of epinephrine so they would all be ready on time, and waited until they drew up all 10 before they handed off the first one. So all of a sudden the doctor would recognize, oh, it was not a bad nurse who was trying not to give me what I needed. She was trying to be so helpful, but next time we should hand off the first epinephrine before we draw up the next 9. So it was, they left feeling much better about the debriefing than if you just said, okay, we have to get the epinephrine to the patient faster. Okay, I'll do better next time, doctor. It's quite a different feeling. But we still feel we're hardest on ourselves. We judge ourselves much worse than Pasquale judging us. We judge ourselves much more harshly.
Yes. My preoccupation is that the young doctors, actually, I don't see more question on the chat. So I think that the people believe that this kind of approach on resuscitation is not very important. It's more important to know how many milligrams of drugs are important, and the teamwork is less important. I don't know. This is my impression. I don't know, Margherita. What do you think about that on Matteo?
Yes, maybe you're right. I think, honestly, I think the teamwork, it's really important. But I don't think that we young doctors doesn't care about teamwork. It's just that maybe we should spend more time practicing teamwork, because often we're alone, so we study. We think that studying theory is the best way to be a better doctor, but actually maybe we should spend more time practicing. And I remember when we practiced for the pediatric simulation games 2 years ago with Matteo and our other colleagues. It was really impressing how what I knew about the emergency was really increasing in like 3 or 4 days in Latina, and I spent like 1 month studying all on my own on the books, and it was really, really different and really less interesting and important. So maybe we should spend more time, and we should remember that it's a big part of our knowledge, that it's the collaboration with our colleagues, and that all alone we cannot save the world. So yes, maybe we should think about it sometimes.
In this way, I think it's very important to have many retraining during the years, because first of all, people go to a simulation, and at the end of simulation are enthusiastic for that, for the simulation, and come back in his hospital and start to have more enthusiasm in the resuscitation. But day after day after day, this kind of emotional implementation slow down. So I think that the retraining is very important, and to change mind of young doctors and the old doctors, because change the mind of old doctors is very difficult, but young doctors alone, they can change.
And one thing to think about is that the most important part of the simulation is the debriefing. So it's possible, in fact, very helpful to debrief real cases. You don't have to wait for a simulation. if we take the same after-event review and debriefing style very briefly after real events, real stressful events, procedures, anything, rounds, debrief rounds, how did rounds go? We can start to integrate this kind of team approach to our everyday practice. And this reinforces it, and makes it easier to take criticism, easier to learn.
Yes, but generally I think in Italy we are not used to asking questions everywhere. Why is not in our DNA? So out of fear, I don't know why, but no, after an event or also in the emergency room, we don't have normally we don't have a feedback about what happened during the resuscitation. So probably we have an emotional feedback, but then we don't discuss about what happened, where we have wrong down. So what do you think, Matteo, about that?
I have a question about the debriefing. And in my personal experience, which is very brief, very short, of course, but I often saw that the most common thing is not to mistake a drug or to mistake a certain intervention, but the most difficult and confounding thing to do is to remember accurate times. In fact, at the end of the management, even if the team was well coordinated, I saw that there is much confusion about when you gave a precise drug or take a certain action. Maybe because everyone seems to be very sure about his point of view, or because the person in charge to remember times often begins to do something else for many reasons. So my question was, how do you suggest to resolve such a common, at least in my brief experience, misunderstanding? And is it very common, or is it or just in my past, in my experience?
I'm sure it's really common. One of the most common. One of the things is, so Margarita was saying, you have to study. Of course, let's assume that there's a basic knowledge of resuscitation medications, etc. Of course, there has to be that basic knowledge. We can't say it's not important. We just have to say it's maybe a little less important, but it's easy to test. That's why we spend so much time on it. It's easy to test the dose, test the drug, right? But the timing is really difficult to keep track on. Just like the dose of the medication may not be so important. We really don't know the exact dose of epinephrine that makes a real difference in resuscitation. A wide range of doses is probably okay. Same thing with time. I don't know that 2 minutes or 2.5 minutes or 5 minutes is exactly necessary. I know early is important, late is important, etc. But keeping track of that time, using communication on the team, making sure someone is assigned to track the time, especially if the team leader is very busy. Can you, Margarita, follow the time and record the times and tell me when it's been 4 minutes since I gave the last epinephrine, whatever it is you're giving? That kind of communication helps. And also asking the other team members to let you know with closed loop communication. Give the epinephrine. I gave the epinephrine and I gave the flush. Time is such and such. Now the person at the head of the bed and the recorder can know what was done when. But if they just say, you say, give the medication, they say, yes, I'll give the medication. But you don't really know when they gave the medication. It's very hard to track. And sometimes the medication is still on the bed instead of actually given.
Okay, Margherita?
No, I just wanted to say something. I remember when we was our experience. It's a lot based on the simulation games, but actually, I will talk about it. I remember that it was for me really difficult to understand when to speak up and when to do not speak up, because I remember that the good teams that were in the simulation games had like a really good team leader, and actually it was almost every time someone was speaking, it was the team leader, and the other members of the team just let the team leader have the feedback when the team leader asked for it. But I remember that sometimes I was in my role and I was thinking maybe I could help the team leader, because maybe he or she is forgetting something that for me it's really important. But I remember that it was difficult to know when to intervene and when it was not the case, because maybe I could confuse people, and maybe I should trust the team leader and let it do. So do you have any suggestion for, I don't know, solve this problem?
This is one of the most difficult things, just like on Zoom when everybody speaks or nobody speaks. Knowing when to speak and when to speak up, when something is so important it needs to be said right now, and when something can wait, is a big challenge for all of us. But I'm going to give you an example here. Jacopo, in 30 seconds, I'm going to ask you to give me a report on how hard the ventilation is. Now, Margherita, let's talk a little bit about when to speak up, when we do blah, 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 blah. Jacopo, now it's your turn. So the team leader can learn some techniques. If too many people are speaking, they can say, I'm going to go back to the ABCs. I'm going to ask airway, then breathing, then circulation. Unless there's something that's life-threatening, let's go in that order. Okay, A, airway. Who's taking care of airway? B, who's taking care of breathing? C, who's doing circulation? So you organize the team, but you've alerted people what sequence they are in line to speak. And if it's so important that it's a life-threatening, like the patient's in ventricular fibrillation, we need to shock them right now, then you speak up, right?
Okay.
But if you know you're third in line and you don't have something life-threatening, of course you can wait for the third in line. So these are some things that you can practice and learn and play with a little bit to see what works with you. Not everything that works for me is going to work for you. So you have to find what works for you to figure that out.
Okay.
And only with simulation we learn that.
In simulation, or if you don't have as much simulation available, you can do it in real events, because, and it doesn't have to be code blue events, it can be relatively minor events, because every day we encounter some sort of stressful event that challenges us, and we can learn from that too. It doesn't have to be a cardiac arrest.
Okay. Thank you very much. We have finished our time. Good day for you. We are finished our day, but you are at the middle of your day. And thank you, Margherita, Matteo, Pasquale.
Thanks very much.
Thank
Hope
you
to see you soon in Latina.
And
Latina.
Yes, and I'm very glad that you remember a lot of things about Latina. It makes me very happy.
And we hope to have you in Rome as soon as possible.
My wish.
Okay.
Stay safe.
Okay. Stay online.